Afternoon. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Leveraging Internal Experts to Prevent Staff Assaults. My name is Shirley Dominic and I will be your moderator for this program. All materials are provided for your educational use. Now I'd like to introduce our speakers for today's webinar. Loni Francis is the Director of Behavioral Health Services for an acute care level 1 trauma center at Reading Hospital Tower Health. Loni is experienced as a nurse leader, both in operations and clinically in psychiatry, and currently leads the Workplace Violence Committee for the hospital. Erin Marinchak is a clinical nurse specialist and Senior Director of Clinical Practice at Reading Hospital Tower Health. In her current role, Erin has oversight for nursing quality, practice, and education for a magnet-designated Level 1 trauma center. She is the co-chair of the Hospital Workplace Violence Committee and has presented nationally on improving outcomes through leveraging the role of the clinical nurse specialist. There are no actual or potential conflicts of interest in relation to this presentation. Loni, I will now turn the program over to you.
Hi, everybody. Thank you so much for taking the time to join us today. We really appreciate your level of interest in this very important topic of workplace violence prevention. I know it's been a challenge nationally that Erin and I are very passionate about over the past couple of years. We both work for Reading Hospital, which is part of the Tower Health system. It is a 700-bed hospital, level 1 trauma center, and we have one of the busiest EDs on the East Coast. So we do see quite a bit of workplace violence, but we've put a lot of things in place that we hope that you'll be able to take away from this presentation. So what we would like you to know is, doesn't matter what size your hospital is, large or small, we hope that you're going to find some interventions that are tangible for your team to be able to implement. And that's our main takeaway that we would like you to see. And some of those interventions being budget neutral. So really our story started as the pandemic was ramping up. At that time, the focus was primarily on policies, procedures around COVID. And at that, we were seeing such a significant rise in assaults on staff and all these things with, streamlined documentation and many of our processes changing, we had lost some of the infrastructure that we had had in place for years. And so we were just really noticing people were scrambling, they were getting hurt. Not only were we having more occurrences, but the severity of the occurrences were so severe. So you can see the picture, and I have permission from both of these nurses who are listed. One's a nurse, one's a PCA. The picture on the left, this woman was choked while she was trying to help a patient put on their gown, and they turned around and pushed her up against the wall. And the one on the picture on the right is another nurse who was merely walking out of a room. A patient was charging down the hall at another nurse, and this person just got in the way and was pushed very hard up against the wall as well. Just being in their path. So these are some of the things that we were seeing as we were just trying to, take care of patients, and it was a scary time. At our hospital at that time, there was some siloing of the different practices. So we had some things that lived in Occ Health, some things that lived in patient safety, some things that lived in nursing, and not all of those things were, or interventions, policies, practices were put in one place. So it was very challenging for the staff to know what they were supposed to do next. So this was our baseline data at that time. As you can see, we really jumped up into the red. This is some nursing data through NDNQI that our hospital tracks. We were well above benchmark at that time and continued to be for a couple of quarters. It was very scary for the teams on the floor, and that wasn't just nursing, it was security, some of our lab and X-ray technicians were getting hurt as well and additionally some other staff. So just awareness of what was going on with the patient wasn't well known from unit to unit or throughout the hospital. So we're going to do a polling question here, and we would like to know, how advanced is your workplace violence team? Are you at the point where you're creating the climate for change, you're enabling and engaging the organization, or you're really implementing and sustaining? And if you could just put your answer in the chat, we'll take about 30 seconds to poll, and that way we can just get some data from all of you participants on really what is needed. Thanks.
Because it looks like the consensus was A, creating climate for change, followed by B, engaging and enabling the organization.
Okay, great. Thank you. And that's where we were for a very long time. So I just hope that you'll find this presentation really encouraging. And it's very difficult to know where to start with this. There, in the past couple years, some more best practices nationally have come out, but it's still very minimal. Erin and I were recently at a national conference, and the majority of people were also at creating the climate for change. So we hope that you'll be able to take away some tangible interventions as you create your infrastructure and policies. Okay, so we did do some polling of the staff, and some of their feedback, that some of the things that we were learning from them was they really didn't even know how to define violence at that time. We did not have a strong violence definition in our policies. And again, there were some one-off incidents. However, this was now starting to happen every single day. And we were seeing anything from physical violence, verbal assaults, sexual assaults or verbal, and the teams really were challenged in how they would even define that. So Erin and I did a little exercise with our practice council, and we put up 10 scenarios around the room, and we asked them to rate every one of those scenarios and if they felt that that was a patient being violent. The truth is 10 out of 10 scenarios were patient violence, patient to staff violence. However, they only rated adult assault to staff as violence. If it was pediatrics or geriatrics, they did not define that as violence. So we found that a very key takeaway at that point. And they could see where in those situations, the developmental age of the patient really played into it, and they had a real soft spot for the patient. The challenge was they weren't putting themselves in a safe position because of the patient's age. So I'm going to turn it over to Erin now. She was able to get on, and Erin's going to talk a little bit about the signage and policy.
So definitely, I think signage is one of the very first things that most hospitals do, and maybe you have it and maybe you don't, but it actually took us a little bit longer than we had hoped, but finally the signs are up, essentially, letting our visitors know, our patients know that violence is not acceptable, and it's our policy to protect our staff. In any kind of a situation. So the signs are up, they're in elevators, they're in public areas. And rather than, I'm not sure the signs themselves had any kind of an impact other than our staff had very positive messaging to feel supported during their in hearing that the hospital was making efforts in order to protect them. So I thought that was one benefit that sort of came out of signage. So again, most hospitals have signage. We certainly see it everywhere. I myself have seen it in vets' offices, in the airport. Right, we see that about being respectful towards TSA staff. So it's not unusual to have signage. But again, in terms of impacting our violence rates, I can't quite say that that it made a major impact, but it was certainly something that we knew that we had to do. Really, something that took us a while from a team's perspective was to recreate the signage outside patient rooms and in the medical record. This is something that had been rolled out several years ago. I don't know the logic or the rationale behind creating an orange cross on a blue background. That wasn't our initial team, but we wanted to re-roll it out. Something I noticed working at the bedside during COVID, although I was in a leadership role, like a lot of you, during COVID, we all kind of went back to the bedside. And I was caring for a violent patient. There was that orange cross. It was a magnet outside the patient's room. I knew the person's history and the fact that he had assaulted healthcare staff during his stay. But I watched a phlebotomist go into the patient room, kneel by the bedside. He was asleep, and start to perform phlebotomy. And it occurred to me then, I am a clinical nurse specialist, so we do tend to dig into processes and want to correct the bigger picture. And I thought, they have no idea what that even means, right? I quickly ran in and I just kind of stayed by her side to make sure she was okay. But the vast majority of our staff outside of certain units that had held on to that magnet and that orange cross, most people didn't know what it meant. It had been many years. A lot of us put things into place, and through time and turnover, they don't always get integrated into education or onboarding, and so they just are kind of taken for granted. So that magnet is something that we've chose to do, and in addition to that, then creates a banner in the medical record. And I think that I have some more slides coming up that might show that a little bit more clearly. Let me see. Oh, you can see in the screenshot above the orange cross, it's a red history of violence. I could go on forever about the EMR and the changes that we've made. So if there are any questions, please just reach out to me and Loni directly. There's a lot to this, and a lot of people are very hesitant to want to put signage outside the door. They're hesitant to put signage in the medical record. When you take judgment out of the situation and you look at it as a way to protect the staff, and for all of us who are very patient centric, if you look at it a way to add the messaging into the EMR about what happened, what the triggers were, and how to prevent it, it becomes less of a lot of people had accused us of a scarlet letter. And when we were doing this work, there's now a scarlet letter on my patient's chart. And I'm like, that's not necessarily the reason, and it's not necessarily, doesn't need to be looked at that way. It's to protect our staff. And most importantly, all of these events, many of them could be prevented just by knowing, more details about what had happened going in. So a lot to be said about the door identifier and the EMR, but the banner is there. And with that banner, we use Epic. So there's a flag. We expect that there's details in that flag that are objective, and that there's enough information in there to guide the staff in preventing a future event, if that helps. So again, the magnet, now that most of you can see the picture, is the orange cross in the navy blue background. That's a magnet that goes outside of our patients' doors. And again, that was established before Loni and I had taken leadership of the team. So I don't have a rationale as to why that was chosen, but that's what we have chosen. The signage, which you can see all the way to the left, is for our visitors, our patients, and those are posted in public areas, our elevators. And then the upper right, where you see there is a banner that goes, we use Epic. You'll see the more screenshots throughout that. Whenever a history of violence flag is entered, we have the banner come across, and the expectation is that enough information is entered into the banner that prevents with triggers, preventing a future event, and just giving some staff into the insight of what actually had happened in an objective manner. One thing before we had the visual issues, I wanted to talk about staff training. We do have a tiered level of training for staff. So all of our staff no matter what your role is, coming into Reading Hospital gets a basic overview of de-escalation and workplace violence. All nursing personnel, all nurses, LPNs, patient care assistants get a little bit more in-depth training. And then for areas that we have worked as a leadership team to deem as high risk areas, so patients that are more prone to escalate based on diagnosis. Those that are cohorted in those areas receive MOAB training. We went from CPI or nonviolent crisis intervention training through CPI to MOAB with some hands-on, a workshop that they get sent to, and then every 2 years as well. So we can move on to the next slide, and I think I'm handing it over to Loni for the next slide.
Yes, thanks, Erin. So as you can see, it took quite a bit of time to just develop the infrastructure, which was the training, policy, visual cues, things within our EMR. And then we really tried to hone in on different roles within our organization and what was everybody's role. And so one of the first groups that we worked with was the leadership group after the staff. And so the leaders were saying, okay, once this happens, what is my role in this? And so here's just a basic overview of something that we actually put an appendix in our policy, and it's for all staff throughout our system and leaders to be able to understand so that we're providing consistent interventions, not only for the patient, but also in support for the team members. So as you can see, tier 1 is verbal threats, and then that escalates to what we call a tier 3, which is continued persistent physical or verbal aggression towards staff. And then it tells the person who they escalate to and what the leader's action is to be. We would really like to see, once this starts, that there's immediate intervention with the patient from a level above the direct care clinician. And this takes it into a very objective place where we have a philosophy as a system, and this is how we treat the team members that work here. And we expect that of you as the patient. Is there something that is not meeting your needs that we could provide for you to help your understanding or, make your stay more comfortable? And usually it stops there. Just having this in place, we already had started to see a lot of progression in our data in a positive direction. And staff were starting to feel more supported. So that was a huge piece of this at the beginning. And something that we actually did not measure is more of the subjective view of how everyone felt when we were going through this. And it was just too big. There were so many things happening at that time. And really, some of this was on fire, where we just needed to put some things in place to keep people safe. So this was very beneficial. And like I said, it is in our policy. And this all was happening right before the Joint Commission had decided to make this mandatory for all health systems to have something like this in place as far as workplace violence prevention. So again, we had a previous leader that worked here, and one of her phrases was, we build the bridge as we're crossing it, and that's what we were doing here. So Erin and I really dove in on this. We developed a learning board. That's a tool that we use here in our organization, which is a date where you identify a problem, an action owner, and really the goal of what you want to do. So there's many forms of that, but we had a lot of ideas, we had a lot of problems, and so we needed to get that down and get organized. We did 2 workplace violence gap analysis to really look at our hospital needs as well as system needs. And that was led by the system level, actually. Something that we added that was very, very beneficial for us is weekly case reviews. So This is a 100% manual data pool from our reporting system. But what we didn't know was, what did our data as a hospital look like? There was a lot of suggestions of what it could be. Oh, it's all the behavioral health patients. Oh, it's this group of patients that are coming in and they're the ones that are being violent, which turned out not to be true. And we'll talk about that a little bit more. And so we've been able to form a small sub-team of our Workplace Violence Prevention Committee. We are very consistent still to this day in meeting weekly. We debrief on all the cases that come onto this report. And we talk about what could have been done to prevent it. This has also prompted the leaders on the unit to be asking those questions of the team as they're putting their review into the incident reporting system. It's still not at perfect yet. There has been a lot of learnings that we've taken away from that, and then we're able to take that back to our hospital level workplace violence committee, and that's where that team is able to make some change on a hospital or system level. We also, this is an example of this picture that you see on the right side of the slide. We engaged with our house supervisor team. They're a very small team for a very large hospital, yet they respond to all of our codes, and they developed this debriefing tool. One of the things that we learned from staff was that after a violent event, even if there were a bunch of people on the unit, once that event is over, everyone disperses. So like any code, and this is also where we had to change everyone's thinking, just like you would do with a code blue or any other type of immersion code, you want to debrief with everyone afterwards. There's a protocol on how you handle it during the code as well as after. And that really supports everybody in how is their well-being. Did we have, process improvement needs that we could implement immediately? And so we gleaned some learnings from that as well. And then we really communicated to the leaders what their follow-up expectations were. I kind of spoke about that. We're emailing them in the moment as we're reading some of the incident reports to say, hey, I see you met with the person. What exactly were your interventions as the leader? Never meant to be punitive, just to enhance the conversation as well as the level of support for the employee if they have become a victim of workplace violence. So here's an example. I just want to show you kind of a visual where we were when we were initially engaging leadership, which was on the left. And this is what it looks like in this actual report from our incident reporting system, where everyone just said they reviewed it and nobody really had any follow-up, to what is now the type of feedback we're getting in our incident reporting system from the leadership on how they followed up with the staff. You can see here, emotional support provided. They put an intervention in place for the patient. There's a little bit of background for our team on what was going on with the patient and how they communicated that amongst the care team. So that's really that higher level of communication amongst the care team that we're now expecting. Okay, and I'll turn it over.
Oh, thanks, Loni. Just because this presentation is titled Leveraging Our Internal Experts, security was somebody that we partnered with very early on. Pros, if you've ever engaged with security in your own areas related to workplace violence prevention, you would know this. And they're really engaged. They were just so wonderful to work with, whether it was their leadership or the individual guards that we have. They were absolutely and are absolutely willing to round. That was never a question. They had always done rounding even before we, I believe, re-implemented our team. They were rounding. However, it was more of a check in with the facilitator. Any issues up here? No. Let's move on. And I'm going to talk a little bit about how we kind of changed that. And they they take de-escalation training. Now, at the time that Loni and I were revamping the team, they were taking a different training than nursing. And so we, as a leadership team, thought it was important and beneficial that they were taking a little bit of the same training as the nurses. They do have a slightly different program, but it's within the same, it's within Moab as well. And we kind of work together to develop and refine that training as a nursing team and a security team. The thought that we could partner with our security guards to print a list in Epic and have them round on the high violence patients was really difficult. They don't have the same access and the same views that we see. We had, just to let you know, some trial and error that we went through. We tried to submit a list to them daily or every shift and have them round. But in the end, it turned out to be just a little bit more, I don't like to use the word scripting here, but just kind of saying outright to the facilitator when you're rounding, who are the patients that have been violent within the last 24 hours? Who are the people that you would like me to round on, or the nurse that you want me to round on? And we also paired them. Loni's going to talk in a little bit about how we brought in our behavioral health nurses in a different role. Pairing security with them has been fantastic, and can't wait for you to hear about that. But security is just they're one piece of an important puzzle in reducing violent events. Now, we also worked with our security director to develop different tiers of help. And I mean, you could go into that all day long, right? Our distress, our distress calls versus calls just for care, scheduled care. So some patients just need a little bit of security standby to give meds to, or get them out of bed and ambulate them. So it's been a process, but security's been wonderful. The issue, like I guess most of our roles, is there's just not enough of us. So we would love to put a security guard on each unit or each of our high risk units, but I think we finally found something that worked. So something in between a dedicated security guard on each unit and just walking up to a facilitator and saying, "You're good." Fine. So we've really come to a happy medium there with our partners in security. Oh, engaging informatics. Oh my gosh. So, like many of you, a fair amount of our workplace violence work ends up engaging the electronic medical record and the people who help us with our tickets, right? So we went through years of changes. As I kind of alluded to early on, we initially had, when I first started at the hospital and at the bedside, there was a flag that said the patient was violent and you had no idea what had happened. I just remember being in the middle of the night next to a guy's bedside. I'm looking at him, he's looking at me. I'm thinking, what? I mean, are we gonna have a problem here tonight, bud? Like, I just didn't know why he was marked violent. It scared me. I'm sure he's thinking, why, what's happening here? So really, any kind of a flag without data or an understanding of what happened, especially because a fair amount of our violent events involve people that don't have full cognition intact, is really unfair to staff, and it's unfair to the patient. So it's important for us to have as much information in the medical record as possible. So I'll start on the right-hand side and just show you, again, I've mentioned several times we use Epic. All the way on the right-hand side, we have our properties list where you can see the Vs. Please disregard the red and the black. That doesn't mean anything, and it's something I need to fix on my end. But this is a unit that shows all of the violent patients at once to help with leader rounding, to help with charge nurse or a house supervisor understanding of where the violent patients are, and just kinds of gives an oversight for somebody like me or another leader or a unit director to kind of have an understanding of where the violent patients are and who needs maybe some extra rounding. When I talk about the flag, again, it's hard if you're not on Epic, but any kind of information that you're putting into the record, we went from a basic flag and a banner to then having a best practice alert, which is that pop-up that happens in the medical record, that pop-up that says, "Hey, the patient has a history of violence. Go into the flag for more information." And it wasn't until about 6 to 8 months of that we realized it makes no sense to have staff have to do another click, and another couple of steps to find the information that they need. So we since revised our best practice alert that all of the information they have on the patient and why they were violent pops up immediately as soon as they enter the record for the first time. And it's hard to read, and that's, I wasn't trying to pull content here, just kind of a visual for you, but it just shows directions on the patient. Hey, listen, this person might not like to be cared for by a male. This patient might not like to be touched when they're walking. These are the things that go into helping our staff understand how to prevent a future event. And at the bottom, we need them to acknowledge the statement or indicate that it's an emergent situation. Our hospital really doesn't like BPAs, and I'm sure you don't either, right? We want to be very careful about the things that staff have to click through in order to care for the patient, but we felt this was so important that they didn't have to go hunting and pecking, and that it alerted the care staff from the minute they logged in that this patient has some different needs and needs to be cared for a little bit differently in order to protect themselves. And so, this is where we get into implementing and sustaining the change. Loni and I and our teams have been at this for years now. This started during COVID. And so we're at least about 4 years in. We did see an initial increase in reporting, which is exactly what we wanted. And I know we have some Reading Hospital patient safety team members on the call today. They've been pivotal in helping us modify how staff put in an event report. We have to meet weekly and go over these events. It's still worth the time we put in. I don't want to get too much into that now in our meeting structure, but it's a lot of meeting time. But this time it's worth it to make sure you're reviewing each event, that you understand the trends. We added additional data elements. So very early on, it was very clear to us that our patients who were committing acts of violence were like unintentional, whether it was a brain injury, a stroke, dementia. We see a lot of elderly that are hurting our nurses and our staff. And so you obviously change your approach based on the type of events that you're finding. And I think, if Loni didn't allude to it, something we have to continuously keep coming back to is, I know everybody wants to talk about the national stories that you see and the worst story that you can think of that has happened within your own facility. But the vast majority of events that are happening on the daily are cognitively impaired, at least at our hospital, unintentional, and minor injuries. And so we don't even want that happening, because those are what stress your staff out over time. It's not normal to come to work to be kicked in the stomach or punched from a patient in the bed, or scratched, even a scratch that maybe sends you to employee health. These are the things we're trying to prevent. And so people get naturally very emotional about workplace violence, and our team only focused on patient to staff for that reason, because it's another team for us that talks about guns and protecting our staff from visitors who come in with weapons. That's not the focus of our team, and that's not, really where our data is showing that we need to be, if that makes sense. So that's why Loni and I felt very much like we had to focus on the patient in the bed, because that's where the number of assaults are happening. They're not chasing us very much out of the room. They're in the bed, and it's when we're leaning over them. And it's the cognitively impaired, and that helps guide your efforts as a team. We always should chase the data, right? We need to have the data, the baseline data, to understand where we're going. And so that has absolutely been worth our time, collecting as many data elements as we can around these events, categorizing them. Like I said, we have it broken down by time of day, by type of person who's injured. The vast majority, not surprising, RNs and PCAs. And so when I do these presentations with Loni and other members of our team, we want to make very clear that we do know other types of hospital staff are getting hurt, but it has to be, please don't quote me on this, it has to be 98% to 2%. Oh, and our security guards often bear the brunt of some of our, especially in our ED. But those are the people who are going to focus our training on, right? And we break it down by unit, and we break it down to even, did they have meds ordered before? Did we give them meds? So there's just so many data elements, and we don't have that in our RL reporting system. And then so it's a manual pull, but it's well worth it. And then the last thing that we still need to press on ourselves to do, because it's been 4 years, is to make sure we're giving these updates to staff and leaders. So we use our nursing practice council as our primary sounding board. We have a nurse from every division that sits on that council. Before we make a change, we go to those unit level or org level councils. But it's important because we kept our team very small so that we could move faster. So it's important for us to go to leadership, go to different divisions, kind of let them know the progress that we're making for their safety. And that's been really good as well, but it's more time and you have to be real intentional about providing those updates. Loni, over to you.
Thanks, Erin. So one of the other internal experts that we engaged was 2 psychiatric nurse consultants, one full-time, one part-time. And they were on our psychiatric consult team, and we basically changed their role or their main focus. So Erin spoke a little bit about with security and their willingness to round, and what we needed was to actually partner them with some experts, and that way they could get the correct information from these nurses. The nurses can connect with the charge nurses on the floor a little bit more and be more intentional in the questions that they're asking. And then security has that information to pass on from shift to shift. So everybody's getting that communication. Everybody's eyes are on the same highest risk patients in hopes that we would prevent it or be there very quickly should something escalate. So here's just an example of something that they're currently putting in the chart. The nurses are putting in the chart, and it's their behavioral management recommendations. They're very, very specific. So in nursing, we do nurse care plans. If anybody uses the EMR, you know that they've now moved to a very canned plan and aren't always patient specific. So what they're doing is something very patient specific to give staff some guidelines and tools on how they're supposed to approach that patient. So this is coming at them right in the beginning when they're getting that workplace violence, or excuse me, the violence prevention flag when they're opening the chart. And we wanted that to happen. So like Erin said, if any role is entering into the chart prior to entering the room, they're aware before they touch that patient, how that patient wants to be touched, how they want to be talked to, if they need additional support in order to prevent any type of violent event. This has also worked in our discharge planning and getting patients out quicker because they're not having events over and over again. We're able to kind of stop that right where it stood, either preventing an event or minimizing the number of events per patient. So here you can see once we implemented their role or their focus, I guess I should say, how many consults they were doing a quarter and how much that really increased. And so the reason that really started to jump up there is because they started developing relationships with the teams on the floor. So it was frontline clinical staff as well as security. And that partnership has really grown to where now we're kind of, so enculturated that we wouldn't know how to do without this role. So the nurses are speaking with security. They're letting them know who the patients are that they need to be rounding on. Charge nurses and bedside nurses are calling the nurse consultants to discuss patient cases. And a lot of this has been at the elbow education. It's not them coming in and taking over a patient. It's them just coaching someone who might be scared to care for a potentially violent patient, teaching them how to document or what to document, or even just role modeling how to approach the patient. I did see a question come across: who writes the behavioral management recommendations? And that is the psychiatric nurse consults. They're the ones that are writing those. Okay, Erin's going to talk a little bit about our data.
Yeah, so again, this was years of work. If I had to say, you can see there our incredible progress. This is NDNQI. We log our injury assaults as well as all assaults, but from an NDNQI perspective, injury assaults on nursing personnel, we finally were green for the first time ever in more than 2 years. And again, what really concerns me looking back is how we hadn't really even been encouraging staff at some points to put in to report incidents of workplace violence. So the fact that, and I know you can't see back past 2022, but the fact that we were that high without even encouraging, nurses in particular really don't like to report events. It takes extra time, right? That's always my question with them, or my comment, and I always get a laugh out of them. They don't like it, right? And so the fact that our events were that high even before our team really got started is incredible to me. That means they were getting hurt quite a bit out there. And again, these are injury assaults. And so you can see quarter over quarter a decrease in the injuries. And that's really what we're going for. I mean, we certainly look at all events. We look at verbal, we look at physical aggression, but we really needed our staff to stop getting hurt. And of course, we record data on all staff, but I always really enjoy benchmarked data. And so we have that with our nursing assaults. And this is our injury assault rate on all staff. Important to know that this is a manual poll, right? We have to do this within our team, but again, something that's well worth it. Some of these, which we don't always indicate on the graph, could be one or two patients causing multiple assaults. So we do need to be better at that. These aren't necessarily all, when you see a rise in your injury assaults, it's not necessarily a rise in the number of patients, right? We have had, oh gosh, just last month we had one patient cause assault 6 different people in one event. And so that's important to know. It's important to let your executives know that you're looking at that as well. But this is the number of injury assaults, and we were proud to see a decline in this is all staff. Therapists, providers don't report to very much, and we're trying to turn that around, but therapists, security, nursing, and so it's important that again that we look at all staff. And so this is the end. There's just so much more to talk about, but we do have limited time. So the key takeaway is it's a culture change. It took us years, and that was with a completely engaged executive team willing to support us, and everybody's definitely willing to support us. It just takes a long time. Every change in the EMR, I don't know about your hospitals, but those are never very quick, right? It takes a while to get approval. It takes a while to build, takes a while to communicate. And really, I talked a lot about it in a few slides back, so I won't go too much in depth again, but you absolutely have to use your data, not emotions, to drive your actions. So again, everybody wants to talk about the horrific events, and I do understand that those need to be discussed as well. But when you're working on your workplace violence program, at least, you need to follow that 80-20 rule and look at 80% of the events that actually are happening instead of the emotional. And of course, our patient safety, they work to dive into those as well. But it's just important that you keep your wits about you and use your data to drive your actions. The clinical staff participation is absolutely key. We do have clinical nurses on our team. We have security on our team. It's important that you're getting their buy-in. Everybody on here knows that, but it was important for us to have them help us build every step along the way. And leveraging those internal experts. We don't get extra FTEs, right? Like most of you, we have to use what we have, and we have some amazing experts, whether it's geriatrics, behavioral health, security, even our bedside nurses have been wonderful in helping us build this program. And so hope this has been helpful for all of you. If you go to the next slide, our contact information is there, and I will turn it over to Shirley for questions.
Thanks so much, Loni and Erin. That was a great presentation. Lots of good information. We already have some questions coming in. We're going to move over to our question and answer period. If you have questions, as a reminder, please type them in the chat box found in the lower right hand of your screen. Direct your questions to all panelists, and we will try to answer as many questions as we can. If you don't see the chat box, just click on that chat bubble at the bottom of the screen, and you should be able to see the chat box opening. So first question is for Erin. The question was that it says, all staff are educated on de-escalation, and what was the other topic?
Yeah, so all staff coming in is just the basic principles of de-escalation. So I believe the content focuses on even people that work in offices at our hospital. It's just very, very basic and not as lengthy. And then we get into, as you go down kind of our algorithm, depending on your role, it becomes a little more in depth on de-escalation, a little more clinically focused for the nurses, and then nonviolent interventions and how to escape a harmful situation unharmed. So it just kind of starts at the top and with the basics, and then just gets a little bit more in depth.
Great, thank you. And for either of you, this next question, how much hands-on practice for de-escalation and self-protection does the staff receive? Repetition helps reinforcement.
Erin, do you want to take that one?
Yeah, I can, and you can help fill in. So we, again, for the nurses that we have deemed high risk areas, they nurses, PCAs, LPNs, and our security staff, they do the MOAB training, which I believe has changed to some didactic, and then 4 hours of hands-on training every 2 years. Now, something that our CNO has just commissioned us to start is some violence prevention simulations at the unit level. We chose a unit. We just did an awesome pilot. It went incredibly well, and that was a full-blown simulation with actors and very hands-on for the med-surg nurse to avoid a violent situation. So that's just budding. That just happened. It was a lot of work, but it was pretty awesome. But for the MOAB, it's 4 hours every 2 years. Am I correct on that, Loni?
Yes.
Okay, next question. If and how do you think patient violence towards staff has direct or indirect implications for patient safety?
I'll take this one. It's Loni. We have a very close relationship with our patient safety department. They're really the ones that are helping us drive this. So this is patient safety, something that is being looked at. Patient safety and risk from a higher level at our system is how we incorporate some of our expectations of violence prevention to the patients in their admission packet and in patient rights. So I see patient safety as an equal partner.
Thank you. Next question, do you use any type of screening tool to predict potential violent patients similar to a fall score or maybe different types of other tools that are out there?
Yeah, I can take this. So I think it's been about 2 years now since we chose the DASA score. There aren't too many out there. So we chose to do the dynamic appraisal of situational aggression. Our clinical nurses at the system level had the chance to look at both the BRUSET and the DASA. I had attended a magnet conference where they presented the DASA, and we felt it was just simpler for the staff. They liked it. So it's more of a violence predictor tool, and we have had, I think, pretty great success with that. In other words, the vast majority of our violent events have shown, about 80% of them have shown a high DASA score prior to the event. So I think, whatever you choose to use, the bottom line is this screening tool is different from falls, from pressure injury, from any other kind of screening tool, in that it's there to protect your staff, which is how we've used it to drive change. No staff nurse wants more documentation to do. But what Loni and I were seeing, along with our sub team, was the patients were showing clear signs that they were showing clear signs of escalation. And as a busy clinical staff nurse, it's not easy to identify those signs. It was easy to Monday morning quarterback, but the staff needed a tool to use to say, hey, the likelihood based on this patient's behaviors, the likelihood that this patient is going to strike out at staff or lash out or become violent in the next 12 to 24 hours is pretty high. And that's what that tool does for us. So I did see somebody in the chat say, how do you find it? You can find it on an internet search, dynamic appraisal of situational aggression. We reached out to the authors of the tool. We got a manual, loved it, loved what they said, loved what it stood for, and we implemented it into our EMR. I hope that helps.
Thanks so much. Erin, you've mentioned MOAB training versus CSI a couple of times, and we're getting a couple of questions about. Can you talk about what the differences are and why you decided to go from one to the other?
Yeah, I didn't lead that part of the team because I'm not, my expertise is not in behavioral health. I do know our CNO is here, but perhaps Loni can explain a lot of that too with her specialty. Loni, do you recall? If not, maybe we could call on Ann.
Well, I just know that we had the one program for an extended many years actually, and we brought multiple members of an interdisciplinary team together to evaluate both programs, and we felt that MOAB actually met our needs more, and that some of the practices were a little bit outdated from the other programs. So we wanted something that was not only current, but also going to be easier for our team to understand. And we were able to teach to them in a little bit less time. There's a hybrid. Erin mentioned this in the presentation. There's an ability for hybrid as far as doing some pre-work online, and then an online portion. And then if you're in those high-risk areas, similar, you do the in-person portion of that, but it's not the 2 full days.
Okay, thank you. Our webinar will be ending soon, but we have time for a few more questions before we end the program. Next question that we have, Erin, I think you presented this, but either one of you can talk about it. How challenging was it technically to get the messaging into your EMR? How long did it take? And how long did the actual build take? I know you said that there had been many reiterations, but for someone who's kind of starting that journey, what would you advise as far as a time frame?
Oh gosh, I guess it depends on the size of your facility. We're a system, a health system. Maybe most of you are as well, but we really can't get anything approved without going through many, I would say up to 8 different councils usually. And so when we try to implement something, we give it 6 months, but a smaller hospital or health system may be able to do that in less time. And I did want to be clear about all the things we presented. I believe, it is my belief based on somebody that does the data, every month and looks at interventions and where we really turn the tide for a violence event. It absolutely, in my mind, is the EMR changes, those behavioral health recommendations, and those rounding by our mental health resource nurses were absolutely the 2 things that really changed our world at Reading. That's when we saw our injuries take a nosedive, if that helps. So if people were looking to put their efforts into, I would have those EMR changes, if it's felt to be part of your hospital culture, something you're interested in, and that absolute rounding, because the average nurse without behavioral health training doesn't necessarily see those signs. We're caring. We want to be close to the patient. We want to have our faces close to them. We want to, lean over them when we listen to lungs. And it's just our nature to be close and to touch. And I know it seems very basic to anybody with a behavioral health background, but it's not basic to most of us. And so they needed that at the elbow teaching, like Loni alluded to really understand that sometimes you need to take someone else in with you. You need to back away from the bed, and you need to learn how to come back another time to do the care that you were there to do if the patient appears escalated.
Awesome, thank you. For either one of you, if a patient is intentionally violent, how do you handle administrative discharge?
I'll take this one. That's a great question, and I'll tell you it's a hot topic at our system level. We currently are not administratively discharging patients from the inpatient setting. There is a couple examples of that happening in our outpatient arena, but we're a nonprofit community hospital, and so patients do, even those patients that might not be able to return to a certain practice are still able to come to our emergency department. So that's something that, to be honest, we've looked at nationally. I think, there's Pennsylvania state law that might differ from some other states. There's county differences in, how well you're going to be supported by your DA or county administrators. And so that's been a challenging topic, to be perfectly honest, for our hospital. And it's something that came up when Erin and I presented this nationally, that is a struggle across the nation. So I'm sorry, I don't have a quick answer for that.
That was perfect. Thank you so much. I'd like to thank everyone for joining us today. I'd like to thank our presenters again. It was great information. I hope everyone got something out of today. If you experienced any issues accessing the evaluation and/or your certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. This concludes our webinar. Have a wonderful day.